Welcome back. Today we are going to see on the choice of an antimicrobial agent. So if the infection is not treatable locally by antiseptic agents, drainage of the pus or resource by itself, we have to choose an antimicrobial agent, that is a systemic antimicrobial agent, and the choice of it depends on the peculiarities or particulars of the patient, or in simple sense we can say the patient factors. Second, the infecting organism, and third one, the drug or the characteristics of the drug, which is the antimicrobial agent. First, let us see about the patient factors. The first one in patient factors is age. Age is considered as a factor because it affects the pharmacokinetic parameters of many antimicrobial agents and produces age-related effects. Let's see some examples. First one is the conjugation and excretion of chloramphenicol is inefficient in newborn. Therefore, large doses produce gray baby syndrome. Next is sulfonamides. Sulfonamides displace bilirubin from protein binding site, and it can cause chronic stress in the neonate because their blood-brain barrier is more permeable. Next example is the T-half of aminoglycosides is prolonged in the elderly, which cause 8th cranial nerve toxicity or ototoxicity. Tetracyclines deposit in the developing teeth and bones, which discolor and weaken them, and are contraindicated below the age of 6 years because they discolor and weaken the teeth and bones. Next factor we take into consideration is renal and hepatic function. If the patient is having improper functioning or insufficiency of renal or liver, then the dose of the low safety margin antimicrobial agent should be modified. Let's see some examples of antimicrobials which need dose reduction or avoidance in renal failure. Even if a mild failure is there, we have to reduce dose for certain drugs. Let's see which are they. Aminoglycosides, cephalosporins, vancomycin, amphotericin B, ethambutol, flucytosine. Drugs which needs dose reduction in moderate to severe failure. They are metronidazole, cotrimoxazole, aztreonam, meropenem, carbenzylin, fluoroquinolones, clarithromycin, imipenem. And the drugs that need to be avoided if the patient is having renal failure are nalgesic acid, nitrofurantoin, talambicillin, tetracycline. Exception is doxycyclines. And next, let us see some examples of antimicrobials which we need to avoid in case of liver disease. Which needs to be avoided are erythromycin acetylate, pyrazinamide, talambicillin, tetracyclines, nalgesic acid and pefloxacin. And which require dose reduction are chloramphenicol, metronidazole, clindamycin, isoniazid and rifampin. Next factor is local factors. The conditions prevailing at the site of infections greatly affect the action of antimicrobial agents. Let's see them one by one. That is the presence of pus and secretions. The presence of pus and secretions decrease the efficacy of sulfonamides and aminoglycosides. So, drainage of the abscess is required because that can reduce the population of the causative bacteria, suppresses anaerobes by exposure to oxygen, and improves diffusion of the antibiotics into the abscess. So the area should be clean of pus and any kind of secretions for the antimicrobials to act. Next is presence of necrotic materials or foreign body, including catheters, implants and prosthesis, makes eradication of infection practically impossible. Next is hematomas. These hematomas promote bacterial growth. Tetracyclines, penicillins, and cephalosporin get bound to the degraded hemoglobin in the hematoma. So this is the next factor that can affect the action of antimicrobial agents. Next one is lowering of pH at the site of infection. So if that happens, it will reduce the activity of microlide and aminoglycoside antibiotics. Next one is anaerobic environment in the center of an abscess can impair bacterial transport process, which can cause decreased accumulation of aminoglycosides in the bacterial cell. Thereby, the bacteria become less susceptible. Next one is penetration barriers. There are certain penetration barriers at certain site that can hamper the access of antimicrobial agents to that site, such as in subacute bacterial endocarditis, then endophthalmitis and prostatitis. However, trimethoprim and fluoroquinolones attain high concentration in prostate due to ion trapping, which is an exception. Next one is drug allergy. If an antimicrobial agent has produced allergic reaction previously, it has to be avoided in that patient. For example, if a patient is having syphilis and he is allergic to penicillin, then the choice of drug will be tetracycline. Beta-lactams, sulfonamides, fluoroquinolones and nitrofurantoin are notorious for causing allergy. Next one is impaired host defense. Integrity or strong host defense plays a crucial role in overcoming an infection. Neutropenic patients are more prone to have pyogenic infection. A person who is having a normal host defense, in that person we can use a bacteriostatic antimicrobial agent which can bring in cure for the patient. Bacteriostatic means which prevents the growth of bacteria. If an individual is having an impaired host defense mechanism, he or she will require an intensive therapy with bactericidal antimicrobial agents. Next factor is pregnancy. All antimicrobial agents should be avoided in the pregnant women because of risk to the fetus. Safe antimicrobial agents in pregnancy are penicillins, many cephalosporins and erythromycin. Now let us see unsafe antimicrobial agents in pregnancy and what they cause. First one is tetracyclines. It causes acute yellow atrophy of liver, pancreatitis and kidney damage, teeth and bone deformities in both mother and offspring. Then aminoglycosides. It can cause fetal ear damage, that is ototoxicity. Then fluoroquinolones, cotrimoxazole, chloramphenicol, sulfonamides and nitrofurantoin. They are risk to the fetus. Next one is metronidazole. Metronidazole is not teratogenic, that is it will not disturb the growth and development of an embryo or fetus, but they are mutagenic in nature, that is they are capable of inducing genetic mutation. Metronidazole is not teratogenic in nature but mutagenic, that is they are able to induce or capable of inducing genetic mutation. Not teratogenic means they will not disturb the growth and development of an embryo or fetus. Next one is genetic factors. Drugs like primaquine, nitrofurantoins, sulfonamides, chloramphenicol and fluoroquinolones has the risk of producing hemolysis, that is breaking down of red blood cells. And these kind of drugs should not be used in patient having G6PD deficiency. For your information, I'm explaining what is G6PD deficiency. It is a condition that can cause red blood cells to break down in response to certain medication, infections or any kind of stress. So in such patients, these drugs should not be used because they have the risk of producing breaking down of red blood cells. Thank you for watching. Meet you in the next class. Bye.